Thank you. It is clear to me that the audience at this time point consists of only the most dedicated individuals. So I'm very pleased to be here. I'm going to talk about the BCG immune stimulation, and I split my talk into two parts. First, I talk about the concept of vaccines having non-specific effects. And second, I want to tell you about a large vaccine trial we carry out in Denmark right now to try to pursue the idea of vaccines having non-specific effect. Let me see. Talking about vaccines, it is very important to understand and know that vaccines are a very powerful health intervention tool. I just wish to remind you that smallpox, because of immunization, was eradicated in 1980. That polio, a crippling disease with a high fatality rate, dropped dramatically also with only 223 reported cases in 2012. And measles death dropped from 2001 to 2011 with 71%. And vaccines are very cost effective. That is also important here, and widely used globally. Individuals with no vaccination, with no immunization at all, are actually a minority in the society right now. When we use health intervention, widely used health intervention like vaccines, we have some assumptions. Of course we have assumptions, and one assumption regarding vaccines is that the protection provided by the vaccine is specific. One vaccine, for example, the measles vaccine, protects against measles and that's it. And also that the effect of the vaccine is equal among sexes. However, are these assumptions actually evidence-based? 20 years ago, I met a Danish anthropologist, Peter Åby, and he had been carrying out 35 years of observational studies and also trials in West Africa. And it is part of Peter's personality that he questions all the assumptions we use. And he teaches everyone who care to listen to him, to look for unexpected and reproducible patterns when you're carrying out research. And this is Peter, and this is a very quite provocative question that he asked me. For example, me as a pediatrician and also as a scientist, Lone, do you know what you are doing? That is quite provocative. But if I turn the situation upside down here, this is a little Peter. This baby is actually also called Peter. And he was born 4 hours ago. He's a mature child. And I'm going to BCG immunize him here with at this moment. And what if that question, do you know what you are doing, comes from little Peter here? That can really make you speculate. So now I have some questions I would like to discuss here. Are the effect of vaccines non-specific, or do we have any signs of effects being non-specific? And are the effects of the vaccines actually equal among the sexes, or can we see any kind of differences here also? I wish to illustrate that by, I made some drawings how you analyze data in child survival studies, and here we have 8 individuals. These lines are 8 individuals in any kind of a cohort study or a child survival study. And we do nothing, we just observe these individuals in the cohort, and we see, unfortunately, 2 of the individuals die during the study period. Now, here, for example, in West Africa, we introduce a new vaccine here, and we follow this cohort of children, and we observe that even though this has nothing to do with the specific effect of the vaccine, it seems like the vaccine introduced some kind of positive, non-specific effect because the mortality went down and some individuals survived better here. Unfortunately, we have also seen in other studies that we introduced a vaccine, the child got an immunization, and definitely a negative non-specific effect of a vaccine. This can have nothing to do with the specific effect, because all the vaccines that we use, they are of course tested for the specific effect, and that is certainly positive. So if we see something in the overall child mortality and an increase in the overall child mortality after introducing a vaccine, that have to be non-specific. We have also seen consequently in the studies in Guinea-Bissau that the vaccine effect is stronger among the females than among the males. And that may be immunologically explained by that females have a more diverse immune system. I will come back to that later. So even either the positive effect or a negative effect, non-specific effect of a vaccine, we have observed that to be stronger among the females. It is quite a challenge to pursue the observation of non-specific effect of vaccines in trials, in randomized trials, because it is of course considered unethical to randomize children or adults to vaccines in the vaccination programs. However, Peter had a permission to introduce an early measles vaccine, and this study is published in 2010. So he introduced the measles vaccine at 4 months of age and compared children who got the vaccine at 4 months of age to all the other children following the normal vaccination schedule. And he found an overall reduction in overall mortality, nearly 50%. And if he censored out of that data all cases of measles, the drop in overall mortality was still significant, 45%. So that is a really strong effect of the vaccine. In Denmark, like in the other Scandinavian countries, we have the opportunity of having a long history of very excellent health registers. And we also have the opportunity of all individuals have a personal identification number, so we can do national population-based, registry-based studies. And that sounds so easy, we can follow all individuals, and I have made this a very busy slide for you to see it is not that easy. But we have information on all vaccines, immunizations in Denmark. And here a Danish PhD student called Signe Sørup, who is very skilled at handling large amount of data, she made a study where the inclusion criteria was that all the children studied already had the first 2 shots of the pentavalent vaccine. And she used that inclusion criteria to get rid of the healthy vaccinee effect, that children who got the shots are actually also the most healthy individuals. So all the individuals included in this study, they are healthy. And the outcome measure of the study is hospitalization with the infection. So that is also a strong outcome measure, the outcome measure hospitalization. And when you have a very large cohort study, some of the participants of that study will follow the schedule, but other participants of that study will, by some reason that we don't know, not follow the vaccination schedule. So some of the children here, they went from the second pentavalent vaccine according to the child vaccination program to have the third pentavalent vaccine, and that is according to the schedule. And when they had the third pentavalent vaccine, their risk of admission or their incidence of hospitalization with infection was 124 per 1,000 child years. And when these children, they had the measles, mumps, rubella vaccine afterwards, their incidence of hospitalization dropped from the 124 per 1,000 to 90 per 1,000. And that is a significant decrease in incidence rate ratio. So the incidence rate ratio becomes 0.86. Other of these children, they had the second pentavalent vaccine, and they got the measles, mumps, rubella vaccine, and their rate of admission became 98 per 1,000 childhood years. When these children, after the measles, mumps, rubella vaccine, got the third pentavalent vaccine, their incident rate of admission increased to 126 per 1,000 childhood years. And that is a significant increase in admission rate. So this is to show you that even on a population base in a high-income country, we have signs of non-specific effect of vaccines being a reality. We don't know much about what is the mechanisms behind the non-specific effect of vaccines, but luckily last year a Dutch group published this very rich and interesting paper on that the BCG vaccine induces a NOD2-dependent non-specific protection from reinfection via epigenetic reprogramming of monocytes. So that is actually they use the expression trained immunity, and this is the innate immune system. BCG alters the phenotype of the circulating monocytes in humans, and they both in that paper studied human immune response, but they also they had some nice mice studies. And the other figure here is from a study in SCID mice, mice with severe combined immune deficiency. Some of the mice got the BCG vaccine. All of the mice get exposed to the Candida albicans, a fatal infection. And you see that the blue line in that figure is a 100% case fatality rate among the unimmunized mice. But the mice who got the BCG vaccine, they have a relatively good survival here. And just one word on that we observe sex differences in the responses to the vaccines. This busy figure illustrates that after a yellow fever vaccine, a female individual, she activates nearly 700 genes, while the male individual after the yellow fever vaccine activates only about tenfold less, about 60-70 genes. So that was all I wished to say about the non-specific effects. But we have been studying that for very many years, and some years ago I thought the time had come to start to pursue that observation from Africa in a high-income population. First, a word on the BCG vaccine. The specific protection of the BCG vaccine, as you know, is tuberculosis. We use the vaccine for a long time, 100 years, and at the present, more than 100 countries use the BCG vaccine. So more than 4 billion shots have been given, and we also use the BCG vaccine actually for the non-specific effect in the treatment of bladder cancer. We know that the BCG vaccine is a very potent vaccine. It introduces a strong immune response, and we have side effects after the vaccine. Here we have 3 children from the study I carry out in Denmark now, and you see the first little fellow, that is not so bad, but the second got a good and nice pustule on the arm, and that pustule stays there for 4, 5, 6 months, and the third child got even a wound on the arm. But when BCG was introduced early in the 1920s, 1930s, this is a study from Norrbotten in Sweden, and Carl Näslund, a physician, he actually observed that when they introduced the vaccine very many years ago, and he used the expression non-specific for the first time, he observed a dramatic decrease in overall child mortality. And you see here a total decrease from nearly 11% to less than 4%, And that had little to do with TB death, very much to do with something in neonatal mortality. And definitely this was non-TB driven. We have taken the opportunity of that low birth weight infants in Guinea-Bissau. They don't get the BCG vaccine at birth. According to the vaccination schedule in Guinea-Bissau, all children get the BCG vaccine at birth, but not low birth weight infant. In Guinea-Bissau, we don't know the gestational age of the children, but low birth weight infants are, of course, very many of them are premature infants. So we got a permission to immunize low birth weight infants, infants with a birth weight below 2,500 grams at birth, and then to compare these immunized individuals with the other low birth weight infants who didn't get the vaccine. And we found a 45% reduction in neonatal mortality. I believe that is interesting for you as neonatologists. And we also saw observed significant reduction in neonatal sepsis and respiratory infections. And this has nothing to do with the prevention of TB. This is a beneficial, non-specific effect of the BCG in a quite a fragile population of children. Since the BCG vaccine induces a strong interferon gamma response, and that is in a probabilistic shortcut also called a Th1 response, many researchers have speculated whether this could counteract the Th2 response observed in individuals with atopic disease. We have very much atopic disease in developed countries now. Atopic dermatitis, asthma, and allergy. For example, in Denmark, it has a rate of about 30% of the population, both among the children and also in the adult population. So it would be very nice with some kind of effect here also. More than 30 studies have been carried out. The studies are very heterogeneous, different population, ages, settings, and designs. And half of the studies don't find, observational studies that don't find any effect of the BCG vaccine. And half of the studies actually point at a decreased risk of atopic diseases. So what can we do now in the high-income settings? We have to establish evidence. If we see this pattern in low-income settings, we have to find it also in high-income settings to see whether it is relevant for our populations in these settings also. BCG in Denmark is probabilistically called CALMETTE, so we call our study in Denmark the CALMETTE study. And this study, of course, means a lot to me, but I also wish to talk about the study because as physicians, more and more of the trials are in the hands of the pharmaceutical industry, but trials lie very good in the hands of physicians. So I think that is also a take-home message here today. After some years of trying to get funding, the Danish National Research Foundation started to be interested in the theory about the non-specific effect of vaccines, and they gave us a large fund to establish the Danish Research Center for Vitamins and Vaccines. And the CALMETTE study is part of that research center. And very many warm hands are needed to carry out a large trial. The primary study outcome is, will infants who get the BCG vaccine at birth experience 20% fewer hospitalization during early childhood? And the design of the study, we wish to randomize 4,300 newborns and follow these children with the interviews and the clinical examination at 3 and 13 months of age. The follow-up at 3 months of age is because the Danish child vaccination program gives the first shots at 3 months of age. So we wish to look at the pure CALMETTE effect before that time point. And at the follow-up, we measure growth and also development. That is relevant here, isn't it? And morbidity, and among the morbidity measures are, of course, atopic dermatitis and asthma and allergy. And we also, in a subset of the study, bleed some of the children and make a thymus scan examination and collections of urine and stools. On the long run, we will follow these children also by registry-based follow-up. The timeline of the study is here. We started the study in October. We randomized the first children in October 2012. And it is quite a relief for me to say that we stopped the inclusion by November 2013. We will have our results in 2015. The inclusion status, just before I left to come here to Porto, we randomized nearly 3,900. I think we have nearly 4,000 children actually now. Among them are also premature infants, since we saw a very strong effect in the most fragile individuals in Guinea-Bissau. We wish, of course, to include some of these fragile individuals in Denmark also, but they are difficult to get into the study. 121 do we have by now. And I'm also pleased to say that we have a more than 99% adherence in our study at the 3 months clinical examination and interviews. So we managed to see 2,800 children already at the 3 months clinical follow-up. We communicate widely with the parents using electronic communication. We use telephone interviews. We use email for contacts and email the questionnaires. We use an electronic case report form. This large study simply wouldn't exist without all these modern utilities. And the take-home messages here of my speech is, please give the thought of health interventions as, for example, vaccines, the thought that they have non-specific effect. It is interesting. It is also a provocation, but it is interesting, and we have to pursue that. The non-specific effect of vaccines appears to be based on trained innate immunity by epigenetic reprogramming. And we also see sex differences. And it is important in research always to analyze data per sex. Males and females should be treated equally, but we are probably not equal immunologically. And then we have to question our assumptions. That is an obligation, being a physician and especially being a pediatrician, neonatologist, we have to question our assumptions. And we have to establish evidence, like the CALMETTE study. I hope you get the inspiration to do all the clinical trials you would like to. And I will end by this snapshot from our 3 months clinical examination. How do we keep up the spirit doing busy clinical trials? We do that by exactly the same way as we keep up the spirit as the neonatologists and pediatricians, by spending a nice time with the children and the parents and our colleagues. Thank you.